My lady, good afternoon. I hope you can see and hear me all right.
I can, thank you very much, Ms Carey.
Thank you. So Sajid, may I pick up with where I left off before lunch?
Yeah.
And nosocomial infections. We've heard a lot about them, including the rates in waves 1 and waves 2, and it's not that. But clearly, as Omicron emerged, high community prevalence led to high infection rates in health and social care settings. And in your statement, you say that in particular, you were provided with information that during the Omicron wave, there were much higher levels of nosocomial transmission in mental health and learning disabilities healthcare placements and community NHS trusts. And the inquiry has been looking at the impact of the pandemic on child and mental health settings. Were they a feature of high nosocomial rates, as far as you can remember?
So were they, you mean the mental health settings?
Yes.
Yeah.
Yeah.
I think through Omicron, yes. Yeah.
And when you became aware of the higher levels of nosocomial transmission in mental health and learning disabilities placements and community NHS trusts, what steps, if any, did you take to try and address that problem?
Well, I think in all settings, including those, trying to stop the spread of the virus in such settings, nosocomial infections was a priority. But in terms of the steps actually taken, in all cases that I can recall, I took the advice and accepted the advice of Infection Protection Control, which was run by UKHSA, but also with the input of the NHS and others, including the CMO. And I don't remember ever once sort of questioning or wanted to do something different to that, because I thought it was very, very important on such an important issue, to listen to the experts.
And you make it clear in your statement at paragraph 115 that you were not involved in the decisions of the UK IPC cell. So I wasn't going to ask you about that. But more generally, you say in your statement that you weren't aware of concerns around the quality and suitability of PPE. Was there any, by the time you became Secretary of State, concerns that there wasn't enough, it wasn't the right type, or it wasn't in the right location? Can you help with whether there were those kind of issues raised with you?
No, I don't. In terms of, is there enough? Is there enough for the right type? That wasn't really an issue that came up for me. Yeah.
Absolutely. And can you help me to this extent? Were you aware of potentially a distinction between the protective nature of the blue masks as opposed to the protective nature of the FFP3 respirator masks?
I knew that there were different types of masks, FFP3, FFP2, and obviously the sort of what you referred to as the blue masks. I knew that in certain settings, in terms of what I'd been told by the IPC, by UKHSA, was that FFP3 was more appropriate. But in terms of if you ask about the technical differences between the different masks, I wouldn't know the detail of that.
Okay. You do give an example in your statement at paragraph 121 about issues concerning inequalities around PPE.
Yeah.
And so, Sajid, we've heard a lot of evidence about PPE, in particular FFP3 masks, not always being appropriate for either women, for people from Black, Asian and minority ethnic communities, for different facial types, sizes. And you speak of an occasion at a Conservative Association dinner where a Sikh doctor told you about being asked to cut his beard in certain clinical situations. And you say you took the doctor's details as you thought it was a reasonable issue to look into. What was being raised with you by the Sikh doctor, and what steps did you take to look into the concerns that he was raising?
Yeah, so as it says here, that his concern was that for him to comply with, as he understood, to comply with the rules at the time, that he would have to cut his beard, and him being Sikh in this case as a sort of as part of his religion, that would not be something that he could do or wanted to do. What he was suggesting wasn't that he should be allowed to sort of have rules that apply to him that don't apply to others. It wasn't that at all, and that would have been wrong, because just from a scientific medical point of view, if having a beard exposed was a risk, then that should not be allowed, and he wasn't arguing with that at all. But what he said was that there was a clinical workaround, that there was a different type of mask or PPE, in effect, that could be used to cover beards, and that he felt it was effective, and that it wasn't being taken seriously enough and being considered by the NHS because there was such a small minority of people that would benefit from that. I thought in response that what he raised was a reasonable issue, because he wasn't asking for any kind of special treatment. He was the same rules and the high quality of those rules should apply to everyone, regardless of what their faith may or may not be. But if there was a sensible workaround that from an IPC perspective would work, then it should be considered. So in that particular case, I took his details, which was actually a business card he gave me. And when I went back to my office a couple of days later, I gave it to my office and said, can someone please follow up on this?
Right. Were you aware more generally, that example aside, of whether by the time you were in office, the PPP available was more diverse in the sense that it fitted a broader range of people? Do you know whether there was sufficient supplies of wider types of PPE?
I don't know.
Okay.
I wasn't aware of that.
All right. And I think you say in your statement, just finally on IPC, that no issues in relation to ventilation in particular were raised.
No.
Do I take it from that there wasn't any requests through you or via you to improve the use of portable ventilation in perhaps the older hospital estate?
Not that I recall. Right. The only time one time I can recall ventilation being discussed was in school settings,
right,
when we were looking at can we remove some of the restrictions on children attending school or having to go home if someone's infected, but could the ventilation be improved? But that was primarily being led by the Department for Education.
Yeah, understood. All right. Can I turn then to vaccination as a condition of deployment?
Yeah.
And we heard from Mr. Hancock last week that VCOD, if I can use its acronym, was discussed at COVID-0. The policy was introduced in social care settings in regulations that came into force in November 2021. And I think you say in your statement, if it helps you, paragraph 119, Sir Sajid, that the Prime Minister asked you to consider now making VCOD mandatory for NHS staff.
Yeah.
Right? And I think there was a consultation that ran from about November over the course of winter 2021.
Yeah.
We have a letter from the RCN that I'd like to ask you about. Can I have on screen, please, 417535? It's a letter from Pat Cullen, the director at the RCN. It's dated the 22nd of December 2021. And can we see in the, scroll down a little bit, please. Keep going. Page 2. There we are. The paragraph beginning the other current policy, which the RCN asked for, delayed implementation, is a VCOD. RCN recognises vaccination as a key pillar in infection control and disease prevention in healthcare settings and believes all healthcare and staff. But they were concerned about it being brought in, if you read down, that it might further marginalise those who remain unvaccinated and put further pressure on service capacity, i.e. the number of staff available to look after the patients. And they were effectively asking that implementation was delayed. When you received a letter like this, what was your position in relation to whether there should be any delay in relation to the rollout of VCOD? And I know it didn't come into force, but I just want to look at what was being said to you in the consultation phase.
Yeah, so as you say, during this time, this is what, December 22nd?
22nd December 21, yep.
Yeah. The consultation was still going on. The regulations, as it were, for this had been set out. So the government set out what the policy would be, when it would become effective from. The rationale for that, I think I'd stood up in Parliament and explained it. It was supported very widely throughout Parliament, including by Her Majesty's opposition. And we'd made it very clear that the only way this policy works if we stick to the date that we had set out, unless there was some overriding reason not to. And whilst this letter is important and the RCN is important, I was pleased to have regular contact with them, including with Pat Cullen herself a number of times. It wasn't going to change our mind in government, because the policy was introduced for infection protection control reasons, as to protect vulnerable people in hospitals, and this letter wasn't going to change that.
All right. They're not objecting per se. It was merely a request for a delay.
Yeah, but I understand that, but it's a delay today, then a delay again tomorrow, and so forth. So I didn't really see it in the context of let's delay it by a few weeks. I saw it more in the context of can you stop the policy.
All right. Did you receive, in fact, objections from other areas of the healthcare system objecting per se to the implementation of VCOD within the NHS?
Yes, I'm sure I did. I can't remember specifically from which organisations, but I'm sure I did, yes.
All right. So can I summarise it, perhaps, I hope, fairly? There was some support, including from the opposition, some perhaps taking a middle road of bring it in, but perhaps not bring it in now, and then some people who are wholly opposed to it. Would that be a fair summary of where you got to?
You mean in Parliament, or you mean in general?
Generally, as at the consultation phase. All right. And when you sought to bring it in, I won't go through all of the guidance, but it was proposed to bring it in for frontline workers, as well as non-clinical workers not directly involved in patient care, but who may have face-to-face contact with patients, such as porters, cleaners, or receptionists. So slightly broader than the doctors and the nurses and healthcare professionals. Why was it thought important to widen the pool of people that might be required to vaccinate?
Well, because the whole purpose of the policy was to reduce the possibility of infection in a clinical, hospital setting. And just step back here, why was that very important? Is that because the patients, by definition, if they're in hospital, they're ill. They're more vulnerable than the regular population. And if it could be, if the risk of them catching COVID could be reduced in that setting, then that's what we should do. Now, every decision to try and do that, this is a form of infection protection control, obviously is a balanced decision, and it comes with your benefits, of course, but also costs. The benefits, I think, are self-evident. If you can reduce if people aren't infected because they've been vaccinated, or less likely to be infected because they're vaccinated, they're not going to infect someone else. And so I think that benefit was clear. The potential costs of the policy would be if ultimately there were people, including the groups of workers that you just mentioned and referred to, that refused to get vaccinated, then they would eventually leave the health service if they could not be persuaded. And that was a balanced decision. I think we absolutely made the right decision, both at the time and in retrospect, we made the right decision. But the purpose of it was to reduce infection for patients, which meant that anyone that was in a patient-facing role, including porters and cleaners that might come into contact with patients, was subject to the policy.
All right. Can I ask you, please, about some examples that the inquiry has provided you with from our spotlight hospitals, where the inquiry sought evidence from on the ground, as it were, if I can put it like that. And can I just show on screen, please, INQ 474214_13. I just want to look with you, Sir Sajid, at the impact it had on the hospitals and the kind of work they had to do in preparation for the rollout of VCOD. And this is an example taken from Lewisham, the Queen Elizabeth Hospital in Lewisham. They had about 3,000 staff at that hospital. And if you look at paragraph 2.37, one can see there that in January 22, the Trust Board confirmed that 973 permanent and 282 bank staff who were in scope for mandated vaccine had yet to demonstrate they'd received both vaccinations. By the end of the month, the numbers had changed slightly. And then they actually did some work breaking down the group. And if you look in the middle of that paragraph, the analysis undertaken by the Trust at this time demonstrated the lowest uptake was amongst the most junior roles within the organisation, i.e. all clinical support roles, the vast majority of which were healthcare assistants. This was particularly worrying, as all roles within these professions would be categorised as frontline and therefore fall within VCOD. In addition, the uptake of the vaccine was poor amongst the Trust Black and Bangladeshi communities. Black staff accounted for 29% of the Trust workforce and nearly 54% of those who were in scope. And if we could just scroll down to the next paragraph. VCOD presented a difficult decision for staff who refused to have the vaccine due to the limited ability for the Trust to redeploy them. And you can see there it added to the workload, stress and anger amongst all members of staff, and clearly had a significant adverse impact on workforce morale. So that's an example from Lewisham. May I give you a slightly different example? And could we go please to INQ 472879_7. This is from Warwick Hospital. And paragraph 34, 130 of their staff were in patient-facing roles due to be dismissed, represented 2.6 of the overall workforce. And you can see there the set out that, in fact, there was people had had one dose but had not had received a second dose. And then could we just go over to the next page, please? And paragraph 35, the impact of VCOD cannot be underestimated, particularly the damage to the HR teams. And it goes on, that statement, to set out significant damage to employee relations. There were managers who refused to have conversations with their staff members as they fundamentally disagreed with the government approach. And due to the very late decision to repeal VCOD, which I'm going to come on to, potential applicants for vacancies had already been turned away as they had indicated they were unvaccinated. So a number of different issues there. Firstly, losing staff and not being able to redeploy them. And secondly, the impact on the morale. What steps had you taken during the consultation in the run-up to this guidance being given to ensure that we weren't going to lose a vast number of staff at a time when there was already pressures on staffing capacity?
Yeah, so there were a number of discussions that took place both within the department and directly with the NHS. Importantly, the leadership of the NHS, the chief executive officer, the chief medical officer of the NHS, they supported this decision and its implementation and the fact that it could be successfully implemented within the NHS. And that meant a lot to me because at the end of the day, they would understand the NHS and staffing morale and these issues more than I would. That's their main job, and I took all that into account. They had set up within the NHS a system of communication of why this policy exists, why vaccination is important, how it protects patients, and then also information and sessions available for staff either one-on-one or in groups about the efficacy and safety of the vaccine, and again emphasizing why it was important. So, looking at the examples you've just shared with me, I can still totally understand why it's not in all cases an easy decision to implement, and why it can lead for some employees to anxiety and anger even. But that doesn't mean it's not a valuable policy. I mean, this was an important tool, a very important tool in the pandemic, in infection protection control. I believe we should absolutely keep a tool like this in the box for future pandemics, because we might need it again. And where you have a vaccine for a virus that is effective and safe, and requiring frontline health workers to take it. As I say, it was right at the time, and it's something that I think certainly for me, when you reflect back to it, I think it was absolutely the right policy to follow. We'll get into why eventually it was dropped, but in both cases, when we implemented the policy, dropped the policy, eventually it was led by science and medical fact. And that's the most important thing here. And then we had to think about the practicalities. There were trade-offs, as I said, and you've pointed to some of them, but it was a balance that we thought was the right balance, which was to implement the policy.
I'll come to the reversal of the policy in a moment.
Yeah.
But can I ask you this on behalf perhaps of some others that are in this room? Given that we've looked at potentially a disproportionate impact on Black, Asian and minority ethnic workers who, for whatever reason, didn't want to have double vaccination, were you aware it was likely to have a disproportionate impact on that cohort of staff?
Yes.
Given that you were aware of that, do you think perhaps that in fact the policy shouldn't have been brought in and it wasn't justifiable to pursue it, given that it would have that impact on them?
No, not at all. I think all workers in the NHS should be treated equally regardless of their race.
Can we turn then to the reasons why the policy was not pursued. And it may help you to have a look at the COVID-0 minutes. So Sajid, can I have up on screen, please, INQ 4091577, pages 4 and 5. These are the COVID-0 minutes from the 31st of January 2022. And over the course of 2 or 3 pages, it sets out the reasons, in short, for why VCOD was not in fact brought in. I can take you to particular parts if you wish, but since you were there, can you help us? Why was it that come the end of January 2022, VCOD was not brought in for the NHS and in fact was no longer pursued, I think, within the care settings?
So when the regulations for VCOD were laid out, which I think was early November 2021, what we were, in terms of COVID, what the country, the world was dealing with at the time was the Delta variant. And I believe at the time, some 99% of infections were Delta variant infections. And we knew from the evidence that had been gathered on the efficacy of the vaccines at that point was that in terms of preventing infection, they were between 65%, I think, to 80% effective, depending on which vaccine one had taken. And so it was effective in reducing infection rates and therefore making people less infectious, including in the NHS setting. So that was the sort of the science logic, if you will, in introducing it. Your question was then, why did we eventually decide not to do it? That decision was made in January of 2022. And despite the fact there only being like a couple of months between those November and December, a lot had changed, and that was because of Omicron. So Omicron was discovered after the regulations for VCOD had been laid and the policy had been set out. And gradually, obviously, we learned more and more about Omicron, including 2 very important things. One was just how infectious it was, much, much more infectious in multiples than the Delta variant. And so that by the time we had made the decision to, I think by the time of this COVID-0 meeting that you're referring to, where this decision was made formally in government, I think some 99% of infections then were Omicron and not Delta. In fact, I think in the 8 weeks previous to making this decision, 1/3 of all COVID infections in the UK since the pandemic had begun had happened. And that's how, just to give you a demonstration of how infectious it was. Also, because it was so infectious, it meant a lot of people had, if they hadn't had vaccines, they'd developed antibodies through infection. And also, we learned about Omicron was that although it was more infectious, thankfully it was less severe in its impact than the Delta variant. So taking all of that into account, the infection rates, the fact that it's less severe, the fact that so many people had already been infected, and the fact that actually the announcement of the VCOD, this VCOD policy for hospital settings had led to more and more people taking the vaccine in any case, even before Omicron, and we had the boosting drive because of Omicron, and there's a good take-up of that generally in the country, including amongst health workers. It meant the facts had changed, the scientific facts had changed, and it made sense now to drop the policy, because, as I said, if the scientific facts change, then we should change our minds as well and be open to that, and that's what happened.
Understood. Can I ask you then just about one aspect of the COVID-0 minutes? Could we scroll to the bottom of page 4 and then look over into top of page 5? And if you can see there, I think, Sajid, this picks up on what you were just explaining. The bottom line of page 4, due to the reduced severity of Omicron and the relative number of hospitalisations had halved, the cost of the policy now outweighed the potential benefits.
Yeah.
Right. Go down to the next paragraph, please. You continued, the professional bodies were clear, vaccination was still the professional duty of those working in health and social care, but it was right to question whether a statutory requirement to force people to get vaccinated in order to keep their job was still the right policy, whether it should be dropped. He said that it did not make sense to retain the policy as it would be challenged in the courts, and given that it would be no longer in line with the science, there was a high chance of losing. To what extent did concerns about a loss of a legal challenge impact the decision, if at all, to abandon the policy?
It wasn't unimportant, but it wasn't the reason. The reason was the change in the science and the effect of having this policy.
Right. And then I think in due course, both the policies were abandoned. Can I ask you this? In the event of a future pandemic, would you recommend or advocate for a implementation of VCOD, assuming that there was a vaccine for any new pandemic?
I think it should definitely be a tool in the box. I think it's hard to say today for anyone about whether you should definitely do it in the future or not. But I think that one thing we learnt through the pandemic is that thankfully there was globally a vaccine was developed, and with the UK playing a big role quite quickly, quicker than I think fair to say that people had expected. And the vaccine, as the COVID vaccine, if in the future a vaccine is by independent authorities and respected authorities deemed to be safe, then if we are asking the general public to take it, and it will help reduce infections within hospital settings and make patients safer than otherwise, I think it should definitely be a tool in the box. And it's just worth also knowing that even before the pandemic, the NHS, they have guidelines on vaccines. I think their guidelines are contained in something that they call the Green Book. If someone looks at chapter 12, I think it is the Green Book, it talks about vaccinations of staff in health settings. And while some of those are recommended, it also makes clear there's certain vaccines that all health workers, even today, under the Health and Safety Act, I think, of 1974, are expected to have. And it's not they might have, they are expected to have, and that includes the MMR vaccine, for example. So my point is, it's not unusual to expect health workers to have a higher bar in terms of vaccinations. And I think if I were a health worker today, especially one that is perhaps someone who is thinking of joining the health service, so post-pandemic, I would certainly take into account that a future government, and bear in mind that this decision, when it was made in Parliament, was supported by all the major political parties, so had almost universal support in Parliament. Obviously, we can't speak for future parliaments, but that's an indication of what governments might do in the future. So if I was a health worker today, I would go in with the assumption that this might be asked of me in the future, and if someone doesn't like that, then they can take that into account before they make their decision today on what future jobs they'd like to do.
In short, are you advocating for there to be an expectation that VCOD might be brought in?
Yes, it might be brought in, yes. It's a tool in the box
Understood.
that future governments might use.
All right. May I ask you then, please, about some of the inequalities and vulnerabilities that COVID, to use your phrase, shone a light on? And it may help just to have in our minds, can I have up on screen, please, INQ 309453_8. This is some data, Sir Sajid, that came from the PHE review conducted before your time. But if you can see there in the middle of the page, the rates of death from COVID by ethnicity that have been adjusted as best one is able to take into account location, disadvantage and the like. But one can see there a clear impact on male Bangladeshis, black African men, Pakistani men, Indian men, before we get down to rates of death for white other. And I think you were aware, weren't you, when you came into post, that there was this disproportionate impact on men and indeed women from BA, ME backgrounds. So with that in mind, what steps, if any, did you take to try and address the disproportionate impact of the pandemic? And Sir Sajid, may I say this? We are aware of the white paper that you published in due course, and I will turn to that. But
well, I never published it.
It was never published.
My successors decided not to publish it.
Yeah, quite. That you asked to be published and had done considerable work in getting ready to be published. But before we get to that, did you take any particular steps to try and address this disproportionate impact?
Yes, I mean, I was, as you alluded to, I was aware of this disproportionality before even I became health secretary, just from what I'd read and heard, and I was concerned about it then, even before I became health secretary. But now I was health secretary, I was in a position to learn more and more importantly, do something about it. First, I wanted to understand it. What were the causes of this? In particular, one thing that stuck in my head, I remember being told, was that something like a third of people that presented to ICU with COVID were from ethnic minority backgrounds, and that's almost more than double, I think, the proportion in the population, the general population. So that was very concerned about that, and I think some of the factors are understandable. That doesn't excuse them in any way, but it's understandable in the sense that for lots of reasons that I won't get into, is that people from ethnic minorities are more likely to be in jobs that were more front-facing, that you couldn't do from home, therefore more likely to get affected, more likely to live in deprived neighbourhoods and households, multi-occupation households and all of that. And these sort of social factors, I think, were important. Also, though, I was very concerned or wanted to know about whether in sort of even knowing that was the health service overall responding effectively, doing everything it could to identify causes that might be in the health system and address them. And so, for example, one of those that I came across and took a particular interest in was some of the medical equipment that was being used during COVID, and that was in particular pulse oximeters. And I had read, and then I asked, before I became health secretary, and then I asked specifically, I think in one of my early meetings, the CMO and others to look into this, get back to me. He was concerned as well, the CMO in particular, and they pointed me to some work that had been done by the NHS, but also the Race and Health Observatory within the NHS. And I wasn't satisfied with the answers that I was getting, and that's why I commissioned more work. Eventually, that led to me asking for the conduct of a full independent review, which in the end was by Dame Margaret Whitehead, not just into medical instruments, not just the pulse oximeter, because then I became concerned that maybe this is much more widespread than just pulse oximeters, because maybe these instruments are not being tested on people of all backgrounds and races. Maybe they only use one control group that is sort of white middle-class people, and so there are other groups of people that are being left behind in making sure these types of things work for them. I mean, there are many other things that I did, but that was one of them in particular. And then that review took place and eventually reported, I think, in 2024.
Yeah, I'm going to come on to the review, if I may, in a minute, even though I know that the review postdates your time as a Secretary of State. Can I just ask you about the white paper, though? Clearly, that was prepared in draft, not then pursued by your successor.
Yeah.
In it, though, you make, or it makes the observation that COVID-19 hit hardest in many of the same communities that have experienced poor health outcomes for generations. Mortality rates, and perhaps as we've just looked at, from COVID-19 in the most deprived areas have been considerably higher than in the least deprived areas. This contributed to a widening of existing disparities in life expectancy between the most and the least deprived areas in 2020, and a further widening in 2021.
Yeah.
Do I take it from everything that's set out in the white paper, and indeed what you've just said, that you accept, sadly, that COVID exacerbated pre-existing health inequalities, social deprivation inequalities and the like?
Yes.
And the white paper touches on a number of different areas, including, for example, the need to address obesity, the need to address people with drug problems, people need to try and address people who smoke and in thereby reduce the strain on the NHS. Why did you think it was so important when you came into post to try and address these underlying health inequalities?
Well, I mean, first of all, I've always thought, health. I've always, in my government jobs that I've had, tried to sort of look at the issues of inequalities from many different angles. Health was going to be no different, but as I've alluded to and you mentioned again, is that COVID really sort of exacerbated or shone a light on this, and you could see that certain communities we've just talked about, it could be based on jobs or social background or regions, were just hit a lot harder, and in trying to understand that, it became clear to me that this is obviously a problem, an issue that is much bigger than COVID. It's been long-standing, and therefore much more needs to be done about it. And it needs to be done obviously within my department, specifically with the NHS, but also other parts of my department. So, for example, I had I had inherited a lot. Public Health England had been broken up by the time I got there, but one part of it, which was focused on prevention, I changed its name to Office of Health Improvement, and the Office of Health Improvement Department, and OHID, the Office of Health Improvement. And the reason for that was specifically not just a name change, but it was to get it completely focused on health inequalities. And one of the first jobs I gave to it was this white paper, which I wanted to be a cross-government white paper, and to focus on a central mission was how can we lift healthy life expectancy across the country, but especially reduce the gap between the best areas in terms of healthy life expectancy and those that were performing the worst. And as you alluded to, a lot of that came down to whether it was smoking, it was obesity, it was alcohol or drug addiction, and that's why I wanted this cross-government work done. And it also fitted in with my longer-term plans on cancer and dementia and mental health that I alluded to earlier. Sadly, when I left the department, a lot of work could be done. The white paper was almost complete. I think it's fair to say probably like 95% of it was done. The work on the long-term plans had been done, but my successors decided not to go ahead and publish any of that and act on it.
Can I turn then to pulse oximetry?
Yeah. And
just take it in stages. I think, Sir Sajid, you went on the Andrew Marr show in November of 2021, and you were asked about it by Andrew Marr. And he was alluding to a story in the papers that morning, which basically said that there was a concern that pulse oximeters might not be measuring blood oxygen levels as successfully on people with darker skin. So that was the context. And then he asked you this. He said, it's very serious. Do you think that people have died of COVID as a result of the inaccurate readings? And you said, I think possibly yes. Yes. I don't have the full facts, and that would be a problem. These oximeters are being used in every country. They have the same problem. And the reason is that there are a lot of these medical devices there, or even some drugs and procedures in the textbooks. And you said essentially you thought it was systemic. All right? Now, just acknowledging, as you said there, you didn't have the full facts. COVID oximetry at home was rolled out across the NHS to try and tackle the number of people going into hospital that might not need to be there, and effectively monitor them at home if their oxygen levels plus other readings suggested they needed to go in, then they would be brought into hospital. I wonder there do you think upon reflection that saying some people might have died as a result of this might have put people off from using and taking up the use of pulse oximetry at home?
So can you ask me the question again?
Yeah. To Andrew Marr, you said that you had thought possibly some people had died as a result of the inaccurate readings.
Yes.
At the same time as the NHS are trying to encourage the use of it to prevent people going into hospital that don't need to be there. And I wondered if perhaps, although you had said you don't have the full facts, even saying that there might have been people that died might have actually put off some of the very people that we wanted to keep at home and protect.
No, I don't. I mean, that's certainly not the intention of saying it. The intention of saying it is to set out what I thought was a very serious problem with pulse oximeters, and I've got no reason to think that put people off in terms of using it. But I did think it made the NHS and the wider health system take the issue much more seriously than otherwise. Not just as a result of that interview, of course, but it's obviously the reason I answered the question in the way I did at the interview is it's an issue that I had been spending quite a bit of time on and looking at, and beyond pulse oximeters onto other medical equipment that might suffer in the same way from having a bias, whether that's race or gender or something else. On the NHS, the NHS had noted this issue with pulse oximeters and people with darker skins early on in the pandemic. They had tried to do something about it, but I wasn't convinced it was enough. So, for example, the guidelines, I think I'm right in saying that the guidelines that the NHS issued, and this was before I became health secretary, to GPs and other clinical workers to make sure they are aware of this issue. Even in the guidelines, they said that the pulse oximeters, when used in people from ethnic minorities, might underestimate the level of oxygen in the blood, when actually they should have said overestimate. And so I just didn't, and when I learned that as well, I just wasn't convinced the issue was being taken seriously enough. And also, I could not understand why someone hadn't made the next step, which was, if this is an issue with pulse oximeters, where else could this be an issue? And the NHS just sort of stopped at pulse oximeters and didn't sort of think, well, are there other pieces of equipment that we're using, not necessarily for COVID, but for people's health, that could have a similar problem? And that is why I then ordered the independent inquiry.
All right. Now that inquiry reported, I think, in March, 11th of March 2024.
Yeah.
And it did conclude that for people with darker skin tones, pulse oximeters did overestimate the true oxygen levels, as you've just pointed out. And it was potentially pulse oximetry overestimation gets worse in patients with low or more dangerous levels of oxygen saturation. And if anyone wants to look at it, perhaps we could call up on screen INQ 438-237_51. The review, which I assume you've read, Sir Sajid.
Yeah.
We'll just wait for the...
Well, it came out when I was back on the back benches, but
yeah.
yes.
All right. If one looks there at figure 5, the review very succinctly set out the number of ways in which the low blood oxygen levels and not detecting them could affect at sort of every stage of someone's journey into and indeed out of hospital. So look, if you can see there at the beginning, if you're having COVID oximetry at home or on a virtual ward, means your deterioration goes unnoticed. Again, it might affect you at emergency department, ward level, ICU level. And then in the review, it says what more should be done. The search for equitable solutions is now taxing the minds of many organisations nationally and internationally. And in your statement, you said that you spoke about this publicly and discussed it with your US counterpart. What was the reason why you were discussing it with your counterpart in the States?
There were two reasons. I mean, first of all, because he was my counterpart from such an important sort of partner country, there were a number of things that we've discussed, obviously, especially with the pandemic on. And I met him for the first time. It was at a G7 meeting of health ministers. But I specifically wanted to raise this issue with him because I had read somewhere that his boss, the President Biden, had raised this, had raised the issue of racial sort of taking account of racial inequalities in healthcare in the context of the United States as an issue in the United States, but not specifically about pulse oximetry, but just more generally. So I thought it'd be an issue that he would be concerned about, my counterpart, which he was. But I had a specific suggestion for him, which was that I thought that if there was a way to get the UK and the US to jointly require all medical equipment makers in the world that they procure from to make sure that all their equipment that they produce has been tested on people of all races, then obviously that would be a great outcome. But I thought if the UK and the US did it, the US is the world's largest health market and the UK as the world's, or the NHS specifically, as the world's single largest buyer of such equipment, then it would set a new global standard. And I thought that would be good, not just for the UK and the US, but for it would be globally the right outcome, because so much of this equipment is designed by companies run by white people, tested on white people, and I felt something had to change.
Finally, this on this topic. The review was commissioned, I think, in April 2022, and it was nearly 2 years on before it was published. In your view, do you think that a 2-year intervening period, I won't call it a delay, meant that sufficient action wasn't being taken on what is clearly an important issue?
I hope not. I don't know, because I wasn't there in the department anymore. But one thing I would like to say is I just take this opportunity to thank Dame Margaret Whitehead and her team for what I think was excellent work that they did. And I think the work that she did was completed a lot earlier than it was actually published.
Different topic, please. End of shielding and the decision to end shielding. And
yeah.
So Sajid, you deal with that starting at paragraphs 124 onwards. in your witness statement. You say this: there is no perfect time to stand down the shielding programme. However, your view was that shielding could not go on forever. Can I ask you, please, why, in your mind, was it right to take the decision in, I think it was September 2021, when it formally ended, that was the right time to end the shielding programme? And what steps did you put in place to support those that had been on it and were now going to be off the shielded patient list?
Yeah, so I mean, by the time I had become health secretary, the shielding programme, or certainly the guidance on it, had been paused, and I think it was described to me as it was still kept there as a contingency option. That was the language used at the time. Then the decision then to be made was that, do we keep it as a contingency option, or do we end it? And the reason I decided to end it was essentially just based on clinical advice. Again, it's a clinical sort of decision based on science and the right medical advice. The advice I received was from a number of people, but specifically from Jenny Harries, who was the head of UKHSA, and also the deputy CMO, Jonathan Van Tam. And they were clear that shielding is not without costs. You can think of benefits, but it also has costs, including medical costs. And there were a number of reports and research that had been done that some people that had been shielding, I think it was over 3.8 million people. And so obviously a huge number of people, but many of them had complained of mental health problems, other mental health challenges, isolation, loneliness, and other issues. And so all of that was taken into account, but especially the fact now we had vaccines, and so much of the population, but especially the shielded population where they could take vaccines, were vaccinated. The general population, I think that a high level of vaccination had been introduced, but I think amongst the shielded population, it was something like 91% had received one dose, 88% had received 2 doses. And that meant that we were in a very different position to when shielding was first introduced. So it was a balanced decision, but then the decision based on the advice that I received was to end the programme. And then, just if I may add to that, then we had the discussion about how should we inform people, because it's very important, I felt, to get the communication right. And then I decided that there should be direct communication, and it was suggested to me that maybe the Secretary of State should write to people to let people know the decision sort of made at the top, so to speak, and after a lot of consideration. And so I decided that was the best way to, it wasn't the only way, but it was part of the communication. And I think you then asked what plans we made after we ended shielding.
Yes, I did.
The decision was that not that you just sort of end shielding and that's it and you just move on, of course not, was to make sure that that what we moved to was a policy similar to that existed for clinically vulnerable people and immunosuppressed people, for example, before the pandemic, which was a policy of what we sort of generally refer to as individual risk assessment. So each individual, obviously their medical needs and their situation will be different to others, and that they would get advice from their GPs and other clinicians about what's right for them, rather than a blanket fits-all policy of which was just stay at home.
I think one of the policies that was put in place was what was called the Enhanced Protection Programme.
Yeah.
What did you understand that to practically provide to those who had been shielding but were now no longer, once shielding was stopped, on the shielded patient list?
Well, that was actually became particularly important because soon after we made this shielding decision, a few weeks later, we had the Omicron crisis, and that was for certain people. The list was drawn up by the NHS and input from CMO and others that we thought were particularly vulnerable or remained vulnerable, but obviously weren't shielding anymore, that we had to put in some kind of enhanced protection, especially in light of Omicron. And that was especially because by then we also had more treatments, including antibody treatment. Antivirals. And so those antivirals could be applied. So this, especially where people, either the vaccine wasn't effective enough or for some reason they couldn't take the vaccine, but where the antivirals could be something that could help, and it could be used post-infection as well, which meant that it would be very important to make sure those individuals could access the PCR tests quickly, and also they could be given, those results would be applied quickly, and they also be sent the antivirals. And so we put in a process of identifying these people, informing them, in most cases sending them a PCR test in advance that they could basically keep at home in case needed. And then if they did need it because they didn't feel well, they wanted to check it wasn't COVID, because for them it was particularly important given their situation. There was a special number that they could call where a courier would come and pick up the PCR test, and then if they needed antivirals, that either someone could go and pick them up from a local sort of clinician or hospital, or they'd be delivered to them by a courier. And so the whole purpose of that was to have as it was called, have an enhanced process for a certain group of people, over 1 million, that we thought were particularly vulnerable and needed something more than what existed before shielding.
Can I ask you, please, about an email on the topic of the Enhanced Protection Programme? INQ 3339292, underscore page 3, perhaps firstly, and then we'll come back to your involvement in it. But we are in February, very beginning of February 2022, Sir Sajid, and there is an email about the Enhanced Protection Programme. As discussed, seeing a submission about it, a programme being established to ensure people at higher risk of serious illness from COVID-19 due to a weakened immune system or other specific medical condition are identified and receive appropriate intervention, support and communication, feedback by the end of the week. And then could we jump forward to page 1? And bottom there, hi Phil, Secretary of State has agreed to the points in your submission. We wanted to highlight the importance of communicating / explaining this clearly to those previously in the CV/CEV groups. We need to reassure this group, as there's been strong message to them previously throughout the pandemic about their vulnerability. And we receive lots of communications from these groups about how they feel forgotten about. Firstly, were you aware of communications from the CEV or CV groups saying that they felt forgotten about?
Yes.
Right.
Yeah.
And can you sort of, over what period of time were you receiving those concerns?
I'd say throughout my time as Health Secretary, but especially in the sort of the first 6 months.
Right. Correct me if I'm wrong. I think you said earlier that when the shielding programme ended, the letter ending it was to come from you. Is that correct?
Yeah.
Just help me with the comms then. Do you think that the communications were right if there was still, by February 2022, people saying that they felt effectively abandoned and forgotten about?
Yes, I think both can be right, in that I think it's possible that had I not sent the letter and we did the comms around the shielding decision, it had not done what we actually did, this feeling could be even worse, and because it didn't. The objective wasn't. There were people in this important group that clearly felt that they weren't getting enough communication, and that was something that was well understood and important to me. But I'm not sure that we would ever get to a point where everyone in this group would feel they've had perfect communication. I mean, it was a diverse group, although they had something clearly in common. When you have 3.8 million people, it's some of their priorities within that group can be a bit different to some of the fellow sort of members of their cohort. And so I'm not sure whether we're ever going to get to a position where everyone was going to feel that they're happy with the communications. But I think from what we did in stepping up those communications was important. One of the reasons I was aware of this, by the way, is that it came up in Parliament. I've been in Parliament almost every week, making one statement or other to do with COVID, and quite often, quite rightly, MPs would raise this issue or something related to it. And that was something that was increasingly getting me concerned, to make sure that we're reaching out to this group and we're doing all that we can.
Finally, this please, on the Enhanced Protection Programme. Is it right that the Enhanced Protection Programme did not extend the passporting protections such as statutory sick pay and the like. It was there to deal with more sort of either pastoral or more supportive concerns. Have we understood that correctly?
I think it's right that it didn't extend onto other
Sick pay and
I can't remember exactly when it was, but some of the special provisions around sick pay and other measures were removed and not part of the enhanced programme.
Just small discrete topic, data, please.
Yeah.
Whilst you were Secretary of State, are you aware whether there was any efforts made by the department to monitor the prevalence of long COVID in healthcare workers and obtain data on those sufferers?
On healthcare workers specifically?
Specifically.
No, I'm not aware.
All right. And was there any department or organisation that you were aware of that was monitoring the deaths of healthcare workers from COVID-19 whilst you were Secretary of State?
I'm not aware of a specific department, or I think you referred to the organisation, other than it's something the NHS, amongst the information it was collecting, I'd be surprised if it wasn't amongst their data.
Final topic, please, from me, and this comes to your lessons learned section in your statement, Sir Sajid. Can you help us, please, with any key recommendations that you would urge the Chair to consider in the event of a future pandemic that are specifically focused on improving the response of the healthcare system?
I think it's fair to, even before the pandemic, the NHS was massively stretched. And that's important because the state of the NHS before the pandemic, especially around capacity and how much sort of flexibility and capacity it has, is hugely important being able to deal with a pandemic. And so prior to the pandemic, the NHS has been run by successive governments at almost full capacity. If you look at it in terms of beds, I think the measure is something like they try to aim to run it about 95% of beds are taken. But even if you look at it, broaden that out, if you just look at number of doctors, number of nurses, number of ventilators, number of ICU units, whatever measure you wish to take of the sort of scale of the NHS, it is per capita a lot less than comparable countries with universal healthcare systems. And by that, I'm excluding countries that don't have universal healthcare like the United States. But if you compare to France, to Germany, to Italy, to Japan, to Canada, to Australia, we have a lot less capacity. And I think, first of all, that came through in COVID, all the things that we've been discussing today, because the capacity just wasn't there, and that's why it required a lot of the kind of measures and things that we needed. Which then leads me on to, very quickly, in the what can be done about that. I think there's a fundamental design flaw in the NHS, especially with increasing demand for healthcare, and obviously that the pandemic exacerbated that. But even before that, and it continues, of course, because of new medicines, because of demographics, because of the change in burden of disease. Demand is soaring and supply cannot keep up. And I think one of the fundamental reasons supply cannot keep up is because the NHS is funded almost entirely by general taxation. And that has to compete with other government priorities, and that's true of any government. When I was Chancellor, I saw that firsthand as well. And we're already at a stage as a country where the NHS is, I think today, it's something like 44% of day-to-day government spending. 25 years ago, it was 27%. It's soon going to be over 50%. Soon the entire government will become, in effect, a subsidiary of the NHS. And clearly, that is not sustainable. And so I think the model is fundamentally flawed. And that one can measure that in terms of outcomes, not just in outcomes in terms of COVID, but if you look at whether it's cancer outcomes, it's cardiovascular disease outcomes, it's diagnostics, whatever measure you care to take, the UK, despite the hard work of everyone who works in the NHS, the system is flawed, and we are generally worse than every other country. And that is a fundamental problem with the NHS. So the reason I say this is because I think for this inquiry, to do what I think it's trying to do, which is to learn the lessons from the pandemic and make sure we're better prepared for the next one. If it doesn't try, not necessarily address, but raise this issue of the model the NHS is completely flawed and not sustainable, then I think it's ducking a very important issue. I know that my lady doesn't want to duck any issue in this inquiry, and she won't leave it alone. And the top recommendation I would make, because politicians and all political parties are too scared to say what I say, and they duck this issue because they're worried about having their head shot off if they say these things, is we should have a royal commission that, of the great and the good to look at this most vital issue, because unless it's addressed, then the next pandemic, no matter what lessons you learn from it, we won't be able to deal with it as efficiently as if we had an NHS that in pre-pandemic was actually fit for purpose.
All right. Clearly, you advocate, from what you've just said, for a fairly fundamental or radical reform, call it what you will.
Yeah.
Can I ask, that aside, is there any specific, perhaps more detailed or granular recommendation that you would urge upon her ladyship that you've observed over your time as Secretary of State that could be perhaps more easily implemented than wholesale reform?
Yes, there are potentially many. I mean that, and I'll give you a couple. I can share a couple with you now. But fundamentally, I have to. I think unless this big the elephant in the room is addressed,
yeah,
everything else is just slightly better than window dressing, because it won't deal with the fundamental issue. We will still have massive undercapacity when we get to the next pandemic. Other things that could be done in the meantime are things that you could take parts of the NHS and review those independently of the whole system. The primary care system is not fit for purpose. It was a compromise from when the NHS was created. It doesn't work. It's the worst parts of the private sector, the worst parts of the public sector all combined into one, and it doesn't work. And that needs an independent review. It's something I wanted to do when I was in the department, but it was blocked by the then Prime Minister. And there are other reforms, especially around on prevention. There's a lot more around prevention that can be done. And especially around through better use of vaccinations, better healthcare messaging, and also a lot more work that can be done across government. That was the purpose of my 10-year plans, because, as I alluded to earlier, but I think it's so important, is that there's a lot in terms of better healthcare, especially prevention, that can be done through help from other government departments. But the way the government is structured, the way priorities are set, understandably for other government departments, health isn't always a priority for them. But I think that if all of government came together and worked much better together, there are certain areas such as obesity, such as smoking, such as alcohol and drug addiction that can be better addressed.
So Sajid, they are all the questions that I have for you. Let me turn to her ladyship and see if there's any other matter that your ladyship would like to raise before we turn to CP questions.
No, just to tell Sajid that I have noted the challenge. Not that there was a very great challenge there, just one of the major issues facing us, but I have noted it. No, it's time to go to Mr. Jacobs, please.
Thank you, my lady. And so Sajid, Mr. Jacobs is behind you.
Oh, okay.
But when you answer him, could you speak back into the microphone, please?
Yeah.
Thank you very much.
So, Sajid, just a couple of questions on behalf of the Trades Union Congress.
Yeah.
In describing in your statement the draft white paper, you refer to the recognition that disparities in health outcomes are driven by a number of factors, including the nature of employment. In a similar vein, Chris Whitty has described in this inquiry the importance, in his view, of reducing precariousness in work in a pandemic in order to reduce health inequalities. Do you have a view on the importance in a pandemic of reducing precarious work, particularly in those healthcare roles where there is a lower paid and vulnerable workforce, such as caterers, porters and cleaners?
Yeah. Can I just ask, when you say reducing precariousness, what do you mean by that specifically? Not doing the work, or?
Well, precariousness clearly may manifest in a number of forms, but if we focus it on something narrower, if that assists, something like access to sick pay. So workers having sufficient security in their work that they're not driven to presenteeism, for example.
Yeah, look, so I agree in general with what you referred to as the CMO's view, and I think it would be important to look at such measures. All I would just add to that, though, is that everything is a trade-off, and every decision a minister makes is a trade-off, and take the point around. Let's say if it was, I can see the how. Having some kind of enhanced, let's say, sick pay system for certain roles in a future pandemic would make a difference. But it would have a cost. It would have a financial cost, obviously, and then in government you'd have to think about, what are you not doing to be able to afford that? And so I just sort of would caveat, you have to sort of balance this out. But in principle, I agree with your reference to what the CMO said.
And if on one side there's a pecuniary cost, as you identify, if on the other side there's a cost in terms of increased loss of life and exacerbation of health outcomes for particularly vulnerable groups, do you accept that that's a very powerful factor in favour of taking some action to address it?
Yes, I do. But it's worth remembering the NHS makes this type of trade-off all the time. As you know, the number of drugs that if the NHS could afford them, a lot more people would live, or they'd live longer. But it doesn't buy those drugs because it can't afford them. And so the NHS or the wider sort of government system in terms of public expenditure would have to take the cost of any measure into account.
So Sajid, there might be an impression from your answers that you acknowledge in principle the point being made, but your heart's not really in it when it comes to addressing it as a problem for poor healthcare workers in vulnerable roles.
That would be the wrong impression. I just point out fact, which is that decisions that ministers make have trade-offs, and only a bad minister would ignore those trade-offs because normally in those situations both sides lose and no one gains anything. So I think that what's more valuable in this is trying to set out what those trade-offs are and then how you can work around them. So for example, if this is an issue which I understand and I agree with in principle that is particularly important to, you represent the TUC, right? So particularly important to the TUC, it would be more valuable if they said, if you can give this kind of support to workers in a pandemic, maybe you can pay for it by not giving this kind of support over here that you would do outside a pandemic.
I think I've probably used up my time, but thank you very much, Sajid.
Thank you.
And I did note, Mr. Jacobs, the question for which I did not give you permission, but I'll take it up with you when I see you next in person.
A mere follow-on.
Sorry, I didn't mind, my lady.
Right, Mr. Jory, please. I think he's probably behind you to the right.
Yeah, same direction, Sir Sajid. I asked questions on behalf of the Independent Ambulance Association.
Yeah.
In your statement, you identify 4 ways in which capacity could be increased during the pandemic, and one of these ways was making use of independent sector capacity, which resulted in agreements being signed between NHS bodies and the independent sector. Now, independent ambulance providers already provide about 50% of all non-emergency patient transport services in the UK, but despite the very high level of investment in this area, over £500 million, I believe, there's no permanent national team providing oversight. So looking to the future and what might perhaps be done better in the future, do you think it would be helpful to consider creating a national team to include representatives from both the NHS and the independent sector to address the challenges of providing consistent non-emergency patient transport services?
Yeah, thank you. I think, first of all, I'd say the independent sector played an important role in helping to deal with the pandemic. And that, of course, was welcome. Turning to your question specifically around transport services, I think you said non-emergency transport services. I think it would make sense to have more coordination between the public sector and the independent sector, broadly, much more broadly, but including on non-emergency transport services.
Thank you. Just one other question, please. Again, looking to the future, given the the interdependence between the NHS and the independent ambulance sector, especially in times of surge in demand, do you consider it would be helpful to have an agreed national working protocol between them, including perhaps a register of approved providers and established terms of engagement to ensure that services can be rapidly scaled up when required, for example, in the next pandemic?
Yes.
Thank you very much. Thank you, milady. That's all I ask.
Thank you. Good short answer. I think probably we'll break now because, Mr. Weatherby, you've got slightly longer than time it will take us up to the break. So we'll break now for 10 minutes, if that suits everybody, and return at just about past.
Thank you. Thank you, my lady. My lady, good afternoon. I think the next counsel to ask questions is Mr. Weatherby, King's Counsel.
It is. Yes, please, Mr. Weatherby. Sergeant, he should be almost directly in front of you.
Thank you.
Yeah.
Good afternoon. I ask you questions on behalf of the COVID Bereaved Families for Justice UK group.
Thank you.
Just a few points from me. In your statement, you explained that you had twice weekly meetings with the National Director for UEC, Urgent and Emergency Care. For reference, it's paragraph 112, but we don't need to go there.
Yeah.
And primarily you discussed ambulances and accident and emergency in view of long waiting times, noting in the statement that ambulance waiting times went up considerably during the pandemic. And you explained that there were particular concerns about ambulance stacking during the emergence of Omicron in 2021. So, first point, the data you had that was coming through to you as Secretary of State indicated that ambulance response and A&E waiting times were unacceptably high. Well, that's right,
yeah.
Isn't it?
Yeah.
Now, again, the last piece of evidence you gave when Ms. Carey was asking you questions may have answered this point, but let me put it to you anyway.
Yeah.
But do you agree that response and waiting times and ambulance queuing were long-standing issues which had predated the pandemic and should have been addressed, frankly, before the pandemic?
I do, but my lady has just disappeared from the screen. Do you want me to answer it, or shall we just
pause?
Okay.
Back.
Sorry, I think I pressed the wrong button. Very sorry.
All right. You okay now? Good. All right. So, could you ask me that final bit again, please?
The question.
Not the whole question, just the last bit.
Right. Well, I was putting to you, you'd agreed that the data that you received indicated that response times and waiting times in A&E were unacceptably high. And I was putting to you, do you agree that the response and waiting times and ambulance queuing were long-standing issues that were known prior to the pandemic?
Yes, they were clearly exacerbated by the pandemic, but they were long-standing issues.
Yeah, and therefore, frankly, should have been addressed before the pandemic as general points, not just related to an emergency.
Is that a question?
Yes.
I think that, obviously, I wasn't there before the pandemic, but I think that there were initiatives and measures to try and address it.
Yeah.
But that doesn't mean to say, going back to your first question, it still wasn't a problem when the pandemic started.
Yes, so it was a problem. So, and do you agree that the problem was exacerbated during the winter with its associated risk of high levels of COVID, and was foreseeable, and that once the pandemic had struck, before you came into office, that further measures should have been taken to alleviate the problem before you came into office, so that the winter 2021-22, the position would have been that you'd have gone into that better prepared.
I'm not sure what further measures could be taken or could have been taken that weren't being taken before I got into office, because as you mentioned too, and I've said in my evidence, that I started having regular meetings with the National Director for UEC, and in some cases I would have them more than once a week, and I think I alluded to earlier, I'd ask for the data in advance, start asking for more data and things.
Yes.
I even brought in people from sort of outside the health system to try and give a different perspective,
yes,
and give advice. And I think, although I brought in a lot of measures myself, that's not to say that there wasn't much. There was still, I think, a lot being
yes,
done. I think the problem was that before I was in that role, the real sort of a lot of bandwidth, so to speak, was taken on COVID itself, the vaccines, yes, the delivery of those indeed vaccines, recruitment, retention, and also there was a high rate of absenteeism because of COVID, including in the UEC service.
Yeah.
And I'm just not sure what more you could have done. Okay.
So it's an intractable long-term problem which needed earlier attention. And in the course of the pandemic, it was very difficult to do anything about it.
It was things were being done, but because of the pandemic, the problem it didn't lessen in any way.
Next point, back to 111, and Ms. Carey took you to some statistics, and you were provided periodically with data, and you agreed this morning from the document that Ms. Carey showed you that even by September 2021, something like 25% of 111 calls were being abandoned. The next set of data, I'm not going to take you to it, but a similar document, you've seen it in your evidence pack, it's actually at your tab 10, and for the transcript, it's INQ 479860. There's a similar document, but slightly later. Yeah. So we know from that document that the number of proportion of abandoned calls was about 23.3% in December of 2021. So a similar level, slightly lower. And indeed, from that document, it was suggested that a projection was it was then going to fall in 2022. But do you agree that these levels of abandoned 111 calls were by the autumn or winter of 2021 were unacceptably high?
Yes.
And particularly so, given that members of the public had been encouraged since right from the beginning of the pandemic to use 111 as a first point of contact for non-urgent advice.
Yeah. Well, 111 and possibly their GPs.
Sure. Was this something that you had been aware of generally through the pandemic, that there were problems with 111 and the performance of it?
You mean before I was Health Secretary?
Yes.
Yes.
Therefore, by when you were Health Secretary and by certainly the winter of 21-22, the problems were and had been foreseeable. Shouldn't there have been better planning in relation particularly to staffing by that point?
I'm not sure there could be better planning. I mean, the whole health system, and obviously UEC is a very important part of it, but other parts of the health system we've talked today about, whether it's primary care, acute care, for example, was under stress. There were staffing problems throughout the health system. There were a lot of vacancies going into the pandemic. It was obviously that those problems continued during the pandemic, and that alongside the other sort of infection protection control measures that had to be taken place that reduced capacity and other measures. I'm just not sure there could be, because it was a pandemic, I'm not sure what,
Okay, well,
what else in
Okay,
sort
well,
of practical terms could have been done.
all right, just as a follow-on to that, in terms of a lesson learned for the future, for example, where something is obviously going to be something which is the first point of contact, shouldn't there have been a emergency surge plan for staffing and for telephone banks and the rest of it in terms of 111?
See, because I came in sort of halfway through the pandemic, I hesitate to comment on what happened in terms of emergency services in the first part of the pandemic when I wasn't there. So was there a surge plan or not? I don't know.
Okay. Well,
And so
the inquiry's heard evidence about that, so I won't ask you about that. Let me put it a different way. Going forward, having been Secretary of State for Health, would you agree that there should be a surge plan for services, particularly like 111, for the future?
Yes.
And finally on 111, you at paragraph 112, again, you talk about a, quote, big recruitment drive for call handlers. What I'm not so clear about is when that actually happened.
It started, I believe it started happening quite early on early on as in my term as Health Secretary. Right. And it continued certainly through the second half of, well, certainly from from when I started as Health Secretary, certainly through to November.
Okay, so but this was something that you instituted? Or was
something I supported, something that was suggested by the National Director and the wider NHS, and it's something that I fully supported.
Yeah, but during your term from June 20?
Yes, but it doesn't mean to say that there wasn't something already going on before that was suggested to me.
Yeah. All right, finally this, and it's my last topic, shielding, and most of the points I was going to ask you about have already been asked, so I don't need to do that. But you've told us about 3.8 million people being subject to shielding, and you've talked about the step down or the ending of shielding. Yeah. And one of the things that was needed were individual risk assessments. Yeah. And that's from primary care, from GPs, primarily.
Yeah, primarily, yeah.
Can you help us as to what additional resources were provided to ensure that there would be sufficient capacity for GPs and NHS clinicians to provide individual risk assessments or bespoke risk advice to those who would previously have fallen within the shielding cohort, who are coming out of the shielding cohort, given the numbers involved?
Yeah, well, it wasn't, because it takes time to recruit GPs, clearly it wasn't going to be just sort of a situation where you provide extra funding and suddenly you have more GPs. That wasn't, I felt generally that was not going to be the answer. Yeah. So what was done was to try and take away from GPs other things that they would have ordinarily have done without the pandemic, and sort of reduce their workload so that they could focus more on not just this issue, but increase it later on, soon after we removed shielding, when we had the Omicron crisis. Right. We did more of that. So it was more about reducing, sort of shifting workloads. Right,
so instead of further resources.
And also making sure where possible that some of the resource that you could recruit more easily than GPs, because GPs obviously it takes a long time to train a GP, were sort of other clinical support that might help GPs, not necessarily with that task with doing those individual plans, but maybe take other work off them and release them to do more of those kind of assessments.
So no further resources, but freeing up GP time to do it.
Yeah, there were more resources for other things for GPs, but I don't want to pretend that we thought that offering a lot more financial resource was certainly miraculously going to result in a lot more GPs. It was to use funding to try and shift workloads, to help with workloads in other ways, so it could free up GPs' valuable time.
Thank you very much.
Thank you, Mr. Weatherby. Now I think it's Mr. Simblett, who's just behind you to your right.
Thank you.
Yes, good afternoon, Sir Sajid. These are questions on behalf of the COVID Airborne Transmission Alliance, or CATA, which I think has been in correspondence with you. I'm going to ask you about that in a moment. It's an organisation of healthcare workers and others who came together during the pandemic because they were concerned about the need to protect healthcare workers from COVID's airborne nature, and in particular had concerns about appropriate protective equipment. So I'm going to ask to be put on the screen, please, a letter that was sent to you in April 2022. It's INQ 000300490. There it is on screen. That's the first page. It's the I don't need to go through it. You can see there's a number of constituent organisations in CATA. What I want to, if we can turn to the second page of that, please. You can see it's been signed by Dr. Barry Jones on behalf of CATA, which was then known as CAPA. And they had written to you, I'll highlight the appropriate bit in a moment, suggesting that the risk of transmission of SARS-CoV-2 could be managed in a simpler and safer way by implementing, in particular, two measures that they had bulleted. So if we can go to the top of the page, the second one we need is about booster vaccinations. Needn't worry about that for the moment, but can we highlight the first of those bullet points, please? And I want to ask you some questions about that. So I'll read it out for the record. The clear acceptance of the airborne transmission of SARS-CoV-2 and what that means for indoor environments and the provision of respiratory protective equipment, RPE. This includes FFP3 and similar respirators, which are effective and approved by the Health and Safety Executive for protection against airborne pathogens, whereas the surgical masks currently provided to staff are not. So that's what they were suggesting. So my questions are these. What did you understand to be the route of transmission for COVID-19? Did you consider it to be airborne?
Yes, to some extent, yes.
Right. And in that context, were you aware of previous concerns raised by healthcare stakeholders about the quality and suitability of their PPE, and particularly respiratory protective equipment?
Yes, but not to a very sort of high level. What I mean by that is that I think a lot of issues around, and there were real issues, of course, around protective equipment and sort of PPE as well, were preceded me. And by the time I came in as Health Secretary, there were still issues raised, and your letter here that you point to in April 22 is a good example of that. But it wasn't an issue that was coming up with often. And whenever it came up, like with this letter, whilst I don't, obviously I've seen the letter as an evidence pack, I don't recall it necessarily seeing it at the time, but it doesn't mean I didn't see it. It just means I don't recall it. What I would have done is, after reading something like this, I would have asked my officials to make sure that the people that were, the experts that were setting IPC policy, that's basically NHS and UKHSA, were aware of this. And they would then either give me advice or in a meeting tell me what they are doing about it. So this is saying something specific, which is saying, basically asking for more FFP3 or making sure that and similar respirators are effective and they're approved, as it says here. But that would have been something that we've been concerned about, but it would have been the job of NHS primarily to make sure that is happening.
Thank you. And I suppose in a similar vein, at paragraph 120 of your statement, I don't need that to be shown, you say that you were aware of concerns about the supply of PPE, and you're talking about things like restocking and so on, but not about the quality and suitability of it. Does that mean that you yourself didn't know of specific concerns around, say, the supply of respiratory protective equipment, such as FFP3s? And to what extent were you aware of concerns of the sort that are in that letter?
It didn't come up much for me. And that doesn't mean to say it wasn't coming up within the wider system, including with junior ministers. But it wasn't an issue that I recall as being brought up with me as directly to address.
All right, well, thank you very much. Those are my questions.
Thank you.
Thank you, Mr. Simblett. Miss Hannett, next, please. Usually right at the back behind you to your right. Sajid.
Yeah, got it. Thank you.
Sir Sajid, I ask questions on behalf of the long COVID groups.
Yeah.
I want to start, if I may, by asking you about long COVID in children and young people. You were asked this morning about the ministerial roundtable you attended on the 23rd of September 2021. At that same meeting, Long COVID Kids proposed that a public awareness campaign could help the public understand the effects of long COVID on children. Do you agree that not enough had been done to communicate the risk of long COVID to children and young people by that point?
Look, I agree with the importance of communication on this important issue. I mean, I hesitate to say that your question was asking me to agree if not enough was done. I don't think I have enough information to say whether enough was done.
Following that meeting, then, what specific steps were taken to communicate the risk of long COVID in children and young people?
I can't tell you what specific steps were taken. In the long COVID as an issue was something that my predecessor, I believe, and myself, we took, and my department, we took very seriously. I think we talked earlier about some of the measures, initiatives that we took. The purpose of me having this roundtable and attending it myself, to listen myself to the issues, was to reflect that and to act on that. At the end of the meeting, during any roundtable, particularly that round that we would have taken, my office would have taken note of what was said and what I agreed to. There would normally be a follow-up meeting. I can't remember exactly what was discussed in that follow-up meeting on that specific issue that you raise. But then if my team would have said to me that we will communicate that to the NHS, to the wider health system, and we will make sure that in communications are improved. I mean, generally, I would have, on an issue like that, I think I would have asked them to update me in a few weeks' time what's happened. I don't remember what that update was, but I believe they would have taken action, but I just can't tell you specifically what form that communication took.
And just moving on to now then, do you agree that there should be a public health campaign now to communicate the risks of long COVID to children and young people?
I don't know. I haven't thought about that enough.
Moving on then to long COVID services, you were asked earlier about what was done in response to concerns about long COVID clinics. You approved further dedicated funding for long COVID services in July 2022. In your experience, do long COVID services require continued dedicated funding to maintain the level of services required by the commissioning guidelines?
Yes, I think so. I think that long COVID, as I was saying earlier in our discussions, I think it's very real. I think that hopefully by now that all sort of GPs and clinicians accept it as a very real thing that people are living with and trying to deal with. I think it does require not just continued dedicated services, but also continued research and other levels of support. But your question was about having a sort of dedicated support, and I think given the number of people that are living with long COVID, I think that is justified.
And you've talked about dedicated support, and we've talked about dedicated support and research. Would you also agree that there needs to be specific communication about the existence of those long COVID services to the general public?
Well, I think probably the reason I'm saying probably is that I just don't know what the current communication is, and so it's hard for me to determine whether it's enough or not. But certainly, in principle, should those services, whatever services exist, should they be properly communicated, properly understood? They should, and I hope they are.
Thank you. I'm going to move on now to talk about vaccinations, if I may.
Yeah.
You said earlier that during the Omicron wave, infections were rising and that there was an increase in the numbers of people with long COVID.
Yeah.
Do you think more could have been done and still needs to be done to inform the general public that vaccinations reduce the incidence and severity of long COVID?
If more still needs to be done now, or
Well, at the time, both that's a question that looks both
could more
historically
have been
and
done
to present day.
So sorry, was your question is that could more have been done at the time of Omicron?
Indeed, yeah. Let's start there, shall
Yeah.
we? Start at that point.
Yeah, to inform people that vaccinations work. Was that your question?
Well, that vaccines specifically reduce the incidence and severity of long COVID.
No, I'm not sure more could be done at the time. I think we were doing everything we could to communicate that.
Specifically in respect, do you recall that vaccination communication specifically referred to the effects of vaccination on long COVID?
No, if you're distinguishing between vaccination effect on contracting COVID versus long COVID, I don't think that distinction was made often. But to get long COVID, you've got to have COVID. And so the message is, which I believe at the time of Omicron was very, very clear, is that if you get vaccinated, especially if you get boosted, you reduce your chances of contracting COVID, and therefore chances of contracting long COVID. I think that was clear.
Would you agree, though, that at the time many people were not aware of the indiscriminate risk of acquiring long COVID, and therefore wouldn't you agree that explaining that vaccines had the effect both on COVID and on contracting long COVID, that might have increased uptake?
No, I'm not sure, because I think it might have confused the message. I think I was doing a lot of media at that time myself, so were many others. And I'm thinking about it, and I think if I went out and said, look, get boosted and reduce your chance of getting COVID and long COVID, I just think it confuses the message. So I'm not sure.
I'm going to turn to talk about inequalities. You've been shown earlier that we only have data on the ethnicity of people referred into the long COVID clinics, but not on the number of people who have long COVID overall, i.e. those who have long COVID but aren't within the NHS clinic system.
Yeah.
In fact, there's very little data or research on the impact of long COVID on different ethnic groups and or their ability to access long COVID care. What, if any, work was done while you were in office to better understand how long COVID impacted people from BAME groups?
The data that I had, yes, I think in many cases it didn't distinguish between different ethnic groups, and but I believe later, over time, the collection of data on long COVID improved. I don't know where that eventually got to after I left office, but I think given the fact that we already now know that the pandemic affected different groups, including different ethnic groups, differently, I think having such data is important. I couldn't tell you though what the quality of that data eventually became.
Thank you, Sir Sergeant. Thank you, my lady.
Thank you.
Thank you, Ms. Hennett. I think the next person to ask is Mr. Puar, who is usually middle back as I look at the...
Yeah, I got it. Thank you.
Yes, afternoon, Sir Sajid. I ask questions on behalf of COVID bereaved families for Justice Cymru, who are a group of bereaved families in Wales.
Yeah.
And my question to you is regarding your relationship with devolved administrations.
Yeah.
Now, at paragraph 46 of your witness statement, you describe weekly meetings that you had with your counterparts in the devolved administrations.
Yeah.
And you describe working relationships, good working relationships with a high level of trust. You may be pleased to hear that Baroness Lynette Morgan says something similar in her witness statement.
Yeah.
What she says in her statement to the inquiry is this: I was pleasantly surprised by the amount of contact I had with my counterparts. During the height of the pandemic, the health ministers from each of the 4 nations met almost weekly. This was entirely down to the determination and commitment of Matt Hancock and Sajid Javid, who as health ministers took the relationships with devolved nations very seriously, albeit that I felt that the Welsh Government's influence over any decisions reached by the UK government was limited. These meetings continued until in or around the summer of 2022. So my question to you is whether Baroness Morgan is correct about the lack of influence the Welsh Government had in respect of UK government decisions? Or can you think of an example where the Welsh Government did have influence on the decisions taken by the UK Government, or indeed any devolved administration?
Yeah. First of all, those relations were very important to me. I think they were very important to my devolved nation counterparts, and basically I think very important in addressing the pandemic for the whole of the UK, because as we all know, the pandemic doesn't stop at internal national borders, and it's really important to cooperate and work together. So when it came to working together, I think there was amongst ourselves, that group, there was an understanding and acceptance and recognition of certain things in health were devolved and certain things were not. And so there's clearly actions that the UK government took as for England that didn't apply to Wales or Scotland or Northern Ireland for that matter. We discussed, for example, VCOD earlier as an example. But there were other areas where we were making joint decisions where we could have deferred if we wanted to. But we felt that for lots of reasons, not least having a sort of single message to the wider population and building confidence was important. And that, for example, was on vaccinations, the vaccination policy about when the JCVI had given its recommendations about how it would work and how we would communicate it. When we could have chosen different ways to communicate it, for example, even if we accepted the decision. So you asked me about examples where the Welsh Government, for example, may have influenced the decision. I can think of instances where I think it was Eluned Morgan, obviously, as you said, as the Welsh Health Minister, would suggest when, for example, when we should announce a decision, the way we should announce a decision on vaccines. And on one occasion, I'm sure she talks about something else was being announced in Wales, and if we say it at the same time, it might get. So we took timing into account and the way it's announced, and so there were decisions like that. I'm sure there are others, but I think notwithstanding there was a general acceptance that there were devolved competencies, there were instances, whether it's the Welsh Government, the Scottish Government, or the Northern Ireland Government, where it would have certainly influenced my decision making.
Thank you, Sir Javed. Thank you, milady. That's my
Thank you.
question.
Thank you very much, Mr. Poor. Ms. Sen-Gupta, please. Usually to the left, as I look at the hearing room behind.
Yeah, got it. Thank you.
Thank you, milady. Good afternoon, Sir Sajid. I represent the Frontline Migrant Health Workers Group. Our clients' members include outsourced non-clinical healthcare workers, largely from ethnic minority and migrant backgrounds, and clinical nursing and healthcare assistant staff, all of whom are from a migrant background. Our questions relate to your draft white paper, Health Disparities Levelling Up Health, which was not ultimately published, as you've explained. Ms. Carey asked you some questions about the disproportionate impact of COVID-19 on ethnic minorities, and our questions are about migrant health workers in particular. Paragraph 53 of your witness statement refers to the PHE study of June 2020, Disparities and Risks in Outcomes. That study found a particularly high increase in all deaths among those born outside the UK and Ireland, and those in a range of caring occupations, including social care and nursing auxiliaries and assistants, and the particular vulnerability of migrants and their significantly higher mortality rates during the pandemic. Were you aware of those findings when you commenced your work on your proposed white paper?
Yeah, I mean, first of all, can I say I think that, migrant workers are a very, very important part of our health and social care system, for that matter. And had we not had the level of support that we did from such workers, I think things would have been a lot more challenging and difficult than they already were. Was I aware of those concerns you raised? I think yes, but I can't tell you it was definitely from that same PHE study. I think there was, certainly by the time I became health secretary, there was more of a general awareness, but also I had an inquisitiveness personally about this issue. And so after asking those questions, I became more and more aware.
Thank you. Your draft white paper made only limited reference to migrants. It did not refer in any detail to addressing the health disparities faced by migrant communities, including migrant healthcare workers. You've referred to OHID, the Office for Health Improvement and Disparities. Bearing in mind the significantly higher mortality rates in migrant communities, do you agree that before the next pandemic, OHID should specifically seek to address the health disparities faced by migrant communities, including migrant healthcare workers?
Yes.
Thank you. Thank you, milady.
Thank you, Ms Sengupta. And I think lastly we have Mr Wagner, who's usually sitting somewhere near Ms Sengupta.
Yeah, got it.
Thank you very much. Good afternoon, Sir Sajid. My name's Adam Wagner and I ask questions on behalf of the clinically vulnerable families. I want to ask you first about shielding. I take it from your earlier evidence that you would agree it's important to understand the views and the experiences of those who were asked to shield.
Yes.
Did you consider carrying out any consultation, a formal consultation with those who were shielding to understand their views on how the programme, whether it was effective, whether there was still a need for shielding measures before ending it?
I don't specifically recall thinking about doing a consultation, no. And I don't think it was suggested either.
Would you agree shielding was a novel programme in the sense that it hadn't been tried before,
yes,
certainly in this context?
Yeah.
Wasn't it necessary, given how important getting the views of those individuals was, to do some sort of consultation, to have some sort of objective understanding of the effectiveness of the programme before cutting off the support?
No, I don't think so. I mean, I'm thinking about it now as you ask. I don't think so. I don't think it was necessary because shielding was introduced based on scientific and medical fact. Shielding was removed based on scientific and medical fact. And whilst the people being shielded, all 3.8 million plus of them, are hugely important, and it's important to get the whole policy right, they're not medical or scientific experts. And I think that such an important policy should be grounded in fact.
But you referred before to some of the downsides of shielding, such as, I mean, being stuck inside the home, psychological impacts, not being able to go to work, that sort of thing. But those aren't scientific questions, are they? They are questions of fact.
You're getting that kind of sort of information from people that are being shielded is important. But I do recall when we made the decision, there were, as you asked me specifically about consultation, and a consultation to me has a specific meaning in government. I've never known a consultation take less than 8 weeks, for example, and normally they take 12 weeks, and it's a big formal process. And that doesn't mean to say that you don't have evidence on making a decision, including from those people that are most affected or likely to be most affected. So I already had information, particularly from the CMO in his office, on the issue of some of the negative impacts, the inadvertent negative impacts of shielding. And clearly, obviously, that would point to a decision of removing shielding. And those were taken into account. But I didn't think it would. I don't think it would justify having a weeks-long consultation when I think the science behind it, i.e., that what we had learned already about shielding, about the other sort of health impacts, but also taking into account vaccinations as well, where we were then versus when shielding was introduced. I don't think the consultation was going to change any of that.
You sent a letter on the 17th of September 2021 to the shielding group, advising them that the shielding programme was coming to an end. And in it, you suggested that people could continue practicing social distancing ask visitors to take lateral flow tests before, wear face coverings to avoid crowded spaces, etc. I want to ask you about healthcare settings specifically. Now, Dr. Catherine Finnis of CVF gave oral evidence to this inquiry that advice was and still is in healthcare settings almost impossible to follow, because people who have a high risk of COVID-19, when they visit healthcare settings, they face a lack of structural protections, so lack of ventilation, doctors and nurses not wearing masks, having to crowd into spaces. When you wrote that letter, did you consider the practical implications or difficulties of clinically vulnerable people taking those measures when they went to healthcare settings?
Yeah, I think that clearly that was a general message to 3.8 million people about some measures that they might be able to take. It's not that they obviously had to take those measures, and it's not that in all settings that they would be suitable. But that is why the central message of that same letter was that the key is really an individual risk assessment, which would mean taking into account what's best for that individual, including in certain clinical settings. Because it's worth keeping in mind there are clinically vulnerable people before the pandemic, and sadly there always will be one way or another. And those people need extra layers of protection, including in health settings. And just as before COVID, there were a set of precautions that may be able to put it in place for when such individuals visit a health setting. It's possible sort of post-COVID as well. So I think it was left to an individual assessment to determine how that setting should be approached and what's possible, what's not possible, rather than there being a central policy on it.
But my question was, did you consider healthcare settings particularly and the difficulties that clinically vulnerable people would experience there, especially post-COVID, when obviously as well?
I would say I considered it to the extent that I felt that it was something that would be dealt with through the individual risk assessments.
Do you accept that those at higher risk from COVID-19 remained at that time, remain now, to being particularly vulnerable to being exposed to the virus when they attend healthcare settings?
I don't know about now.
Yeah. What about then?
Yes. Because COVID, there was a lot more COVID around then, and also we had the Omicron wave.
Yeah. And healthcare settings are quite straightforward places to get COVID. Well, you're more.
Well, they could be.
Yeah.
Even though, of course, in healthcare settings there are a lot more stringent controls and infection protection controls than you would have in non-healthcare settings.
Yeah. Well, your predecessor, Mr. Hancock, on Friday, I think, Thursday, said that you were in hospitals were one of the places you were most likely to get COVID at the time. Would you agree with that?
I think that was certainly more the case when he was health secretary, because COVID was just discovered. We didn't know enough about it. We didn't really know how to, as much as we learned much later about how to control infection with it. We didn't have as good ventilation, and we certainly didn't have the vaccines and the treatments, and some of the other medications that we had. So I just think it was much tougher when he was there, and it's not to say, I'm not arguing with your point about healthcare settings. You've got to be much more careful that people may contract it there, but I think a lot of the policies that we had in place was, by the time I was there, were reducing that risk, not least to mention the VCOD policy, because even before VCOD, there were a very high level of vaccinations, and obviously that increased even though VCOD wasn't implemented in healthcare, in all healthcare settings. But when Mr. Hancock was Secretary of State, there was no vaccine for most of the time, and even when there was, uptake took a while, including in healthcare settings.
Finally, I want to ask you about access to antivirals, which is something you've already referred to a bit in your all evidence. In your statement, and in fact earlier today, you say that one of the rationales for ending the shielding programme was the availability of antibody therapies and antivirals. And you spoke about the various ways in which you tried to give access to people who needed those antivirals who were immunosuppressed. Many of CVF's members who are clinically vulnerable, immunosuppressed, or clinically extremely vulnerable, have reported historic and indeed ongoing difficulties accessing antivirals within the required 5 days from the start of symptoms, particularly because of difficulties processing the PCR test in time, and getting a decision to approve access to the antivirals from the COVID-19 Medical Decisions Unit. Can you recall what, if any, processes you had in place to make sure that immunosuppressed people who were at the highest risk from COVID-19 infection were in fact able to access antivirals?
Yeah, I believe on the CEV list, the clinically extremely vulnerable, 3.8 million, I think roughly about 400,000 were immunosuppressed. And for those people in particular, that's where we try to put in place something we discussed earlier, which were the enhanced protection. So alongside the sort of individual risk assessments after we ended shielding, it was a policy of identifying those, and I think it was a process certainly run by the CMO's office, but it was something that I want to say 1.3 million people. It was it was around that number that were on this enhanced list, and the plan was to make sure they had easy access to PCR tests. Many of them sent PCR tests without asking for them, so they had them available, and so that they could be tested and antivirals could be delivered to them quickly if they became infected. That was the policy. I can't sit here and say that I think that worked perfectly in every case. I know that in many cases that was successful, and it did lead to people getting antivirals much sooner than they would have otherwise. But it is possible also that for some people that process didn't work as well as it should have.
Thank you. My lady, may I have permission to ask the final question on the list? I know I'm over time.
You may, Ms. Wagner.
Thank you. Final question on the same point. Do you accept that if antivirals were not in fact practicably available or promptly offered to many people at the high risk of COVID-19, and just accept that, if you accept that as a proposition, I'm not asking you whether it's necessarily correct, would that have impacted on the decision-making process as to when to end shielding and the justifications for it?
Yeah, antivirals were an important part of the decision-making process to end shielding. So I can say certainly it was taken into account that we had them, that they were something that the UK was one of the first sort of countries in the world to procure them, and they were going to be made more available. But having said that, I would say that there were also other factors, and I think probably it's fair to say that the vaccination rate in the country, obviously not just of those in that cohort, but the general vaccination rate in the country were probably more important than the decision making in the decision making than antivirals.
But the vaccinations don't necessarily work well for the immunosuppressed. That's the.
Oh no, that's of course that is true. But what I meant is that the vaccination more broadly in the general population would also mean there's a higher level of protection in the country from infection than there was before vaccinations.
Thank you. Those are my questions.
Thank you very much, Mr. Wagner. I think that completes the questions for you now, Sir Sajid. Thank you very much for your help. I do know what a burden it is to ask you to keep coming back to answer the questions. If you want someone to blame your former colleagues who set the terms of reference extraordinarily wide. But on that point, can I just manage expectations? You set me a challenge earlier, And however tempted I may be to accept a challenge, I am bound by those terms of reference. So I hope you won't be disappointed if you discover that I can't go quite as far as you would like, because I just don't have the powers to do it. But anyway, we'll see how far we can go.
Well, thank you, my lady. If I may just say, I mean, that point I made earlier about the NHS and its general sort of the system it operates under, I do believe, and I think I think it's a vital point in dealing with a future pandemic, and so that's why I made the point that way I did. But I understand what you say, and I hope there is something the inquiry can do about that. That's the first thing, and the second thing, if I can say, is get well soon.
Thank you very much, Sir Jolly. I'm very grateful to you. Very well. We'll sit again at 10 o'clock tomorrow. Thank you, everybody.
Thank you, my lady.